What's up? Doc Mike. Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for May 7, 2021. An update on COVID-19 in Canada with the doses Dr. Brian Goldman. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak to Dr. Brian Goldman, a staff emergency physician at the Sinai Health System in Toronto. Dr. Goldman is the host of 2 podcasts produced by the Canadian Broadcasting Corporation. We speak about the very serious wave of COVID infections now hitting Canada. Let's listen. Dr. Goldman, thank you so much for coming back to Public Health on Call. What's the situation right now with the coronavirus pandemic in Canada?
Well, Josh, pleasure to be with you once again. I wish the news were better in Canada. I think right now we're really at a crisis point in the third wave of COVID-19. We have some of the highest rates of new infections in many parts of Canada. Ontario, particularly Alberta and British Columbia, and to a lesser extent, Quebec. In fact, in Ontario right now, we're seeing 4,400 cases per day of COVID-19. The vast majority of them are variants of concern. So B.1.1.7, the variant that was first described in the UK. British Columbia is a little bit different because, in fact, British Columbia right now has one of the highest rates of P1, which was the variant first described in Brazil, outside of Brazil itself, what's happening is that over the last few weeks, as rates of COVID-19 have gone up and up and up in this country, the lag effect, the lag indicators are hospitalizations and ICU admissions. We've begun to see a big increase in the rates of hospitalization, rates of ICU admission, rates of people on ventilators, to the point that several provinces are in a crisis mode. And it means that we've had to implement crisis procedures. We have more ICU beds than we've ever had before. We are moving patients out of major metropolitan areas like Toronto and moving them into outlying areas. These are people who are hospitalized on ventilators. And we are canceling, postponing elective surgeries, elective procedures, in quite a dramatic way, and we're starting to see rates of burnout among frontline healthcare workers, particularly in critical care and in some areas in emergency medicine.
So it's really a full-on wave of infections, right?
Absolutely, and it doesn't look like a wave in some parts of Canada. It's more like a peak. It's quite problematic to look at, quite worrisome to look at.
And do you think that beyond the variants, there are other contributors? Do you think pandemic fatigue has been setting in Canada and people are having, reluctance to wear masks or to distance? How do you put the different causes together?
Well, we're speculating, of course, but I think that number one overall, it's the variants of concern that are driving this. Certainly to a lesser extent, we're certainly beginning to wonder whether we are reaping the whirlwind of gatherings that occurred during Easter, and whether we're going to see those in the next few weeks. I think that, is it pandemic fatigue, or was it our government's instituting half-hearted measures to try to tamp down the uptake or the increase in the slope of the wave by kind of half-heartedly calling for lockdowns. When the official lockdown was instituted in the province of Ontario, a lot of people were walking around on the street saying, what's different? What changed today? Procedure-wise, rules-wise, it was as if nothing had changed. And you still had essential workers going to work environments where they were themselves at risk of getting COVID-19. I think the underlying thing, which of course, Josh, we're going to talk about in a few minutes, is the lack of penetration of the vaccines. I think in countries where they've had much higher vaccination rates, such as Israel, you're not going to see a third wave or a fourth wave of COVID-19 as sharp as what we've seen here. And I think,
right.
Again, we're reaping the impact of not having vaccines penetrated in our society as much as they have in the United States or the UK.
I definitely want to ask you about that. But before we do that, tell me about the policy response to this. You just described it as half-hearted. Tell me what you mean by that.
So what I mean by that is that we haven't, other countries like Australia, for instance, instituted when they had a big increase in the fall, in late summer, early fall of 2020, they instituted quite sharp lockdowns. They had curfews in some parts of Australia. We didn't see anything like that here. We have, for instance, by lockdown, the schools were not prioritized for being closed. So they were closed about a week after businesses were closed. And so what we had was the rules that were instituted were that non-essential businesses were to be closed. And the problem with that is how you define an essential business. An essential business is where you sell groceries and basic necessities. So it turns out that there are big box stores, for instance, that if they sell a few necessities, they can be allowed to remain open. And so when they're allowed to remain open, you have people in indoor malls, for instance, shopping centers, who are able to congregate. If they're able to congregate, then they're able to spread the infection. You had exhortations by provincial premiers saying, "Don't meet this Easter." Don't meet indoors this Easter. You had strange rules like banning the use of liquor, alcohol in parks, in outdoor areas, when in fact, encouraging people to be outdoors together was probably a smart thing to do from an epidemiological standpoint when it comes to COVID-19.
So it's been kind of a mixed response overall.
Yeah, I think that's fair to say.
And do you think that one of the factors here is Canada's success to date in controlling the virus? That Canada, has done generally pretty well, leaving a lot of people still uninfected. Do you think that is one of the factors here?
Yeah, Josh, I think it is a factor. I think that because we did, so it's a perverse impact of that. If we did well with COVID-19 during the first wave, in some respects we didn't. But much of our outbreaks and deaths associated with COVID were confined to frail seniors. And perhaps there is a bias in our society, an ageist bias, a thought that they're old or frail. If they die, it's because they were frail and they were more prone to COVID-19. And that wave has kind of come and gone. And so because relatively speaking, in younger people, we were doing well, I think that allowed our society to begin to say, why are we continuing to institute these measures? And there was a long time of waiting for vaccines to become available. And during that period of time, there was a lot of pressure to open up schools. There was a lot of chatter in society about the adverse impact of loneliness, the adverse impact on our mental health, particularly in younger people. And so we saw during the winter months a huge pressure to open up schools and you started to hear COVID deniers saying, I'm not affected. I don't know anybody in my circle who's gotten COVID-19, let alone died of it. And so why are we instituting these measures? And so we had the pendulum swinging the other way. So I think there is some sense to that.
Okay, so let's talk about vaccines because, in the United States, we're in a foot race between the virus and the vaccine effort. thinking that if we can get enough people vaccinated quickly, we can spare ourselves this kind of massive surge. There are some parts of the United States that are losing that foot race. There are other parts that seem to be winning. What's the status in Canada right now?
The status in Canada right now is that 7 million Canadians have received one dose of the vaccine. So that's a fifth of the population has received one dose. Fully vaccinated, much less than that. I think the major success that we have had as far as vaccinations are concerned is that we have vaccinated the vast majority of frail seniors, people who live in long-term care. And so any wave will not impact that part of the population, that segment of the population. For the rest of the country, we've had a much slower, or for the rest of the population, we've had a much slower rollout. And that was because we had, serious issues with vaccine supply and logistical issues, which continue to plague us. So the supply issues, now we have large supplies of the AstraZeneca vaccine. I'm sure we can talk about some of the controversies about that. But with the larger supplies of the AstraZeneca vaccine, we're starting to see much more uptake of the vaccine, particularly in younger people, not the very young people for whom the AstraZeneca vaccine is not indicated, but it's certainly, in the 55 to 75 age group. And after all, they are more susceptible to the complications of COVID-19. So that's good news. We continue to have, increasing supplies of the Pfizer and the Moderna vaccines. So overall, if we could, over the next month or two, we're beginning to see mass vaccination centers that are opening and they're open, but are they open for business? Logistically, they've been open. The problem is that we don't have a central vaccine registry that allows us to easily and quickly track who's gotten what vaccine, when they should be getting their next vaccine. And so as a result, there's a lot of logistical issues related to that.
So setting aside the supply issues, these logistical issues seem a little strange to American ears because we think of the Canadian healthcare system as much more, centralized than in the United States. What don't we understand about that?
So what you may not understand about our system is that it is not, it would be easy to think that Canada is like the UK. We aren't. The UK has the National Health Service. We don't have a National Health Service. In Canada, healthcare is almost exclusively, with a few exceptions, a provincial priority, a provincial responsibility. And that means that we have, in effect, 10 provinces and 2 territories of different systems. Each one has its own way, its own priority system. It will dole out vaccines, according to the National Advisory Committee on Immunization. But it doesn't necessarily adhere to this national body. It can make exceptions depending on particular issues that they see in their province. We don't have when I say a vaccine registry, I mean being able to attach a Q code with each dose of vaccine to a particular Canadian, a particular number. It could be a refugee claimant as well. And so using something like a social security number or a health card number, a national identifier number, we don't do that. If we did, then we would know, for instance, that one part of Canada is oversupplied when it comes to vaccines, and so it could shift supplies to undersupplied parts. Then we would have a system. We don't really have that kind of a system. And even in Ontario, one province, we have different provincial health units deciding in their own ways how they're going to distribute vaccines. And so we have different parts of the province distributing to a greater extent. They may have different supplies.
Well, the U.S. doesn't have a single identifier or registry either, and we have a lot of variation at the state level about how vaccines are given out, but there is some consistency to what the federal government is doing, setting up large-scale distribution sites, overseeing the states. Is there that central presence? Do you see the central Canadian government having to step in if there's a problem in a particular province?
This is a major difference between the United States and Canada. If the federal government were to step in that kind of a way, they would get pushback from the more powerful provinces, particularly Ontario, Quebec, Alberta, and sometimes it's done for political reasons. That should be familiar to Americans. Certainly, the federal government is liberal. Most of the provincial governments are conservative. And there is a certain jockeying, although I have to say that in general, they have been singing from the same song sheet. But there is a sense that if the federal government is stepping over the provincial authority, then the provinces are going to call them out on that, and they're going to put that.
Now, we've seen some gaps in equity in the vaccine distribution program here in the United States, with much higher rates of well-to-do whiter populations being vaccinated. Do you have that situation in Canada also, on top of this challenge with logistics?
Gosh, I'm sad to say we have exactly that situation. And there have been a number of newspapers that have been very good at calling this out in the media. The Toronto Star is probably one of the best at doing so. And they reported last week, if I'm not mistaken, that some of the parts of the city of Toronto that have the poorest vaccination rates are the ones that have the highest prevalence of COVID-19 and the working and living conditions that would make people more prone, people who are socioeconomically disadvantaged, people of color, BIPOC populations, and in communities. And so, this is not the first time that we have seen this, but again, we seem to be doling out the vaccine to the parts of the population where they will not have the biggest impact at stemming the third wave.
So what's in the future for Canada? Are you optimistic, pessimistic? Talk to me, maybe short-term, medium-term, long-term here.
So short-term, there's no vaccination program right now that's going to stem the third wave. The third wave is here. It's going to get worse before it gets better. So what we're looking at right now, for instance, in Ontario, is where we go, we have 550 approaching 600 patients in the intensive care unit in critical care beds. That will get to 800, maybe 900. And when we reach that point, we're going to be implementing the triage rules for who gets a ventilator and who doesn't. And I should mention that right now, we're seeing a big uptick in the number of younger Canadians with COVID-19 who are ending up on a ventilator, compared very different from the first wave. And so that's what the short term is going to look like. We're going to see a crisis point in hospitals as vaccination rates increase, as more and more people get at least one shot. We're going to see a big decrease, a sharp decrease in the number of hospitalizations and deaths from COVID-19. And so hospital capacity will increase as we get into the summer months. I am hopeful. I'm optimistic that by September, the situation will be looking a lot better in Canada, but I think it's going to get worse before it gets better.
Well, Dr. Goldman, thank you so much for joining me, and I hope it gets a lot better as quickly as possible.
And I do too as well.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes-Fernandez, and Caroline Wong. Thank you for listening.